I'm Matthew Tolliver. I'm one of the co-chairs of our special interest group along with Juice here. And we have been focused on the pediatric mental health crisis all year as kind of a theme. And each month when we meet, we have been talking about solutions to the crisis, just how it's been impacting us and our work and our clinics. This is, a group that we have a lot of boots on the ground clinician people who are part of the group, but we also have administrators, directors of behavioral health, academic people, researchers. And so we've all been seeing a little bit, I think, from our different unique perspectives and commenting on that. We wanted to go over a few updates at the beginning here. And so one of those is if you have a job that you are trying to advertise for, feel free to put that in the chat. And this can be one avenue for advertising some of those services.
I don't know if people knew too that if you're attending the conference, I guess even if you're not attending the conference, we do have a interns and jobs page in the conference app. So you can send me a description, PDF, a link, and I'll put that in the app also.
Perfect. Well, we had a couple updates that we wanted to go over, and then we'll get into the meat of what we'll do after our updates. Oh, hey, Allie, good to see you. We are going to have a research corner that Rachel is going to lead us through, and then Juice is going to lead us through a facilitated discussion. And so if you haven't been here before, haven't been much, we're a pretty laid back, fun, casual group. You're welcome. We want this to be participatory. We want to get your input and your ideas and your feedback. And so please feel free to interrupt if you've got a question or something that you want to talk about. So in terms of the updates, some of those focused on the CFHA conference that's coming up this next month in October. So Jackie was going to go over briefly just a few updates about that.
Let's see, we have over 550 people registered for the conference. So that's pretty exciting. We have, I'm counting on 600 and my money's on 600. I'm hoping for more than that, but that's what I've been saying all along, which is really good because, obviously first time coming back, flight issues, some people are still really limited with their jobs, what they're allowed to do. Some people have personal limitations. So we're just excited that we're having a big bunch of people coming. And Boise is just a great little town. So I think if anybody's not registered, go ahead and register. It's going to be fun. And let's see, I've got about 50 discussion groups set up. If anybody wants to do a discussion group, they should just send me an email with the topic. And I did send out an email to people just with a know before you go information. So that has lots of information in it. If you have another question, let me know and I'm happy to either add it or send you the information. And I'm trying to think if there's anything else. No, I think it's most of it. Yeah, any questions? Oh, the app is up, so you can download the app and start scheduling your sessions and even scheduling meetings with people if you want. So.
Great.
Rachel, you want to put a PEDS page in there too, just you can find all the pediatric sessions by looking at the track or by doing a search for keyword, or you can also, I put just a page that's as though it's from you guys and just lists all the different pediatric sessions. So.
Great.
So we're also going to have a moment of reunion at the conference.
Yeah.
And I don't know if we have the details already, but if you guys want to join us, it will be great.
Yeah, so that's Thursday during the opening reception, which I think is from 5 till 6. And then at 5:30, we'll have someone hold up a sign that said pediatrics. So one of you just has to come by the registration desk and grab it from me and hold up the sign. And we just use that to kind of, especially for people who are first timers, most conferences we have half the people are first timers. And so if you don't know anybody, it's kind of nice to start to meet some people. So we'll have that going on. And then if you wanted to do any other social activity, let me know. I can add it in. I mean, your SIG meeting is on there. That group meetup is on there. All of the sessions and the ELO are all on there. And then there's also information about how to get the PEDS certificate.
Great. So the two things that we really wanted to highlight for you all was that, like, as Jackie was saying, on Thursday, October 13th, we're going to have a PEDS SIG social from 5 to 6 at the conference. So come for that. And then our monthly meeting is actually going to be at 7 a.m. on the 15th in person at the conference. And so, Rachel, do you want to say a little bit more about the tracks in the conference?
Yeah, I was going to share my screen here for a second so we could talk about the certificate and the ELO. So you've probably heard a bit about our extended learning opportunity. That's Thursday that Jackie and Matt mentioned, first thing in the morning. So the name of the ELO is putting the Surgeon General's Pediatric Mental Health Crisis Advisory into action, practical approaches, tools, and technical assistance. This is really a hands-on, experiential training that we're going to be doing. So first kind of going over the Surgeon General's advisory, the kind of general recommendations, the guidance for healthcare professionals. We're going to talk a bit about solutions to implementing some of the recommendations, and then you'll leave the ELO with a personal action plan. So how to implement one of the recommendations into your setting. So if you're interested, we're super excited to share this ELO with you. You can log in and add the ELO to your registration if you haven't already registered for it, or you can contact Jackie as well. And if you go to the ELO, the next part, you are halfway to getting your pediatric track certificate. So doing this again, this conference. So basically we get for attendees who basically attend different pediatric focus sessions. So if you attend the ELO and you attend at least one other concurrent pediatric session, you can get the pediatric certificate, or you attend at least 3 concurrent sessions that are 30 or 60 minutes. As Jackie mentioned, within the app on the schedule at a glance, all of the pediatric sessions are labeled pediatric, so you can kind of seek those out. And at the end of the conference, we'll have a link, and I believe this might be in the CFHA app as well. And you can go to that link and then basically put your information in to say, hey, yeah, I've attended these sessions, and then we'll send you the certificate. So you can find this information on the app, and we'll send all that information out also after the conference.
Thank you.
Yep.
If you're going to be at the conference and you want to host a discussion group related to pediatrics, we would welcome that, and you can be the SIG's representative for that. Also, if you are interested in leadership positions within the SIG, we're going to be talking more about elections and different leadership positions next time when we meet at the conference as well in October, and we'll be sending more out email about that. But feel free to reach out to any one of us. Reach out to me and I can get you more information about that if you're interested.
And Matt, there are some pediatrics discussion groups already. So I will put that on that list of sessions I have for you. I just don't have that done yet.
That sounds great. Okay. Well, unless there's any other updates, we can kind of move into the meat of what we're going to talk about today, which is cultural and linguistic competence in pediatric integrated care. So every month we try to pick a theme or a topic and hear some research about it, have a facilitated discussion about it. How is this coming up in your practice? What are you noticing? And I think we had talked about, Rachel, you were going to even maybe start us off with our research corner related to a particular article on this topic to kind of frame the conversation, and then Chus was going to lead us through kind of a facilitated discussion on the topic.
Yes, I'm going to share my screen again. Got another lovely PowerPoint. I'm starting off today because the article that I'm presenting on really has a conceptual framework for transforming well child care to address the effects of racism and poverty. So this is kind of big picture type of stuff. And then Chus will be kind of giving an example in her practice, and I hope kind of leads into a larger discussion of what we can be doing at a systems level, but even kind of day-to-day feet on the ground in your practice. So rationale behind this, I think this is no surprise for many of us. There's been many improvements to the delivery of well child care. Many of us can kind of point to the medical home model and attempting to kind of improve access to care, provide comprehensive care, provide culturally competent care. The data shows, however, that current structure doesn't meet the needs of Black and Brown families living in poverty. So there's a gap in terms of health outcomes and, of course, in terms of utilization of healthcare. So in this paper, the idea is thinking big. In order to mitigate some of these health inequities, we need to look structurally. Structural design, redesign is needed in terms of our healthcare system. So what does that look like? So in terms of this framework, they have here kind of the structural processes, which we'll get into, or the structure, then the processes of care, and then the outcomes that we want to see. Many of us are probably familiar with the receipt of care that gets at the medical home model, right? Being accessible, continuous, family-centered, et cetera. That there's different ways that we provide this type of care in terms of anticipatory guidance, et cetera, hoping that this all leads to improved outcomes for families. And what we're focused on here is the structural aspects that can help support these processes and better meet the families in need. So what are these structures, and what could this look like if we're thinking about structural redesign? So authors kind of point through a few different recommendations. So they first start with the personnel aspect. And so some recommendations to give here include incorporating non-clinicians. We've talked in this group about system navigators before, coaches, health educators into a team-based approach. And ideally that you're really drawing from the community of individuals who share kind of a common background and lived experiences of the families you serve. Talk also a bit about facilities. I thought this was interesting in the article. They discussed this idea of decentralizing well child care. So how can you build the capacity of other community-based programs to provide some of the preventative care that we typically provide in our clinics? They give an example, for instance, of Head Start programs completing developmental screenings, for instance. Can we support other programs and organizations of doing some of this work that we do to increase access? Other recommendations they give at the organizational level, again, this should be no surprise for many of us, the work that we do. How do we improve the way that facilities are connected to one another? If we, as we've talked about in here many times, that we make referrals outside of our clinics for perhaps it could be some specialty services or social needs services, and there's no kind of closing the loop. And how do we know that our families access these services and get what they need? And so how do we at an organizational level improve the way that we connect? System navigators, of course, came up as another example. They're not the only example of one way to support this connection to services. And again, typically in a system navigation model, you often have community health or lay workers, non-clinical position, people who come from the community that they serve to kind of fulfill this role and increase trust. Information system, another way to think about improving our systems here, is linking child level data across community agencies and organizations, which is obviously easier said than done. Many of us are lucky if you work in kind of an integrated health system, you might within your health system have access to data, but this is even across organizations that we work with in the community. And if in doing so, finding ways to kind of link data, being very transparent to families about what kind of data is shared with other individuals and how that data is shared. And then finally, all of this depends upon funding. If you're making structural changes such as this, we need new payment models. And of course, a lot of our payment pieces are not, I guess, incentivized to perhaps fund some team-based care or non-clinical individuals implementing some of the preventative services. So again, thinking big about how to restructure our health system would require for things we can think about. I think it also is good to kind of tailor it to, well, what do we do now? And what could I do in my practice today? And so some other recommendations from this article to start thinking about potential members of your current team who can play a bigger role in preventative services. And many of you may be doing that even as a behavioral health professional in that kind of capacity. Are there other individuals who can kind of play a bigger role? How do you create relationships with some of the places that you're doing community referrals? Can you improve the EHR that in such a way to be able to sustain and implement screening and referral processes? Can you change the hiring practices to ensure that the clinic and office staff reflect this community that you serve? So you can think big, you can think practical too, but opening up this discussion of, what are some of the structural changes that we need to promote equitable health care for children and families? How can we advocate for it? What small steps can you take? The article citation is Liljenquist and Coker, and you can see the reference there. So I'll stop my share and open up discussion. Thoughts that people might have.
Yeah, thank you so much, Rachel. I always appreciate you being willing to pull those articles and summarize them for us. That's some extra work, and I think it's really nice to have that as a frame to start our conversations with. Do you want to take it from here and kind of help us think through your material in that context and maybe think together as a group what we do next?
I'll do that. Let me share my screen for just a practical example of how some of these things can happen humbly. Hold on. I think, is this okay? I don't think I can change my view to, hold on. Oh yeah, I can. All right.
Perfect.
So some of these things I'm going to present are already implemented at the PPSC. Some others are aspirational still. So bear with me. So we have a mission until every child is well at the PPSC because it's the mission that aligns with Boston Children's Hospital, which we are affiliated to. And I want to point at the importance of the collaboration among different programs in the organization in order to think about how to provide this culturally and linguistically appropriate care and also advance equity. One of the things that, Rachel, you were mentioning in the review of the article have to do with collaboration across systems, but I also wanted to point at the internal collaborations as well as the buy-in from your organizations if this is going to be something you're going to embark on. This is just an example of how to start looking at whether your organization is serving a representative sample of your state in terms of demographics. Also, referring back to the Surgeon General recommendations, who are the youth at higher risk of behavioral health challenges. This includes racial and minority youth, racial and ethnic minority, and also youth in immigrant households. I have to say that the Surgeon General report also includes youth discriminated by the health system. Among the recommendations is to build multidisciplinary teams to implement services that are tailored to these needs. And here's where it connects with what I was saying at the beginning, that we try to collaborate among the different teams to strengthen these initiatives. Services obviously should be offered in multiple languages in order to be culturally appropriate. This doesn't seem to be the biggest piece, given that there are other aspects such as racism that take precedent. However, if your organization doesn't have many resources or buy-in or cannot tackle things at such a big level, or you are not part of those initiatives or included, which is another issue, you can start thinking about the language aspects for this. That includes, the medical record and screening instruments being translated, etc. So the PPSC has some interpreter services and culturally and linguistic appropriate services project. And the goals for this year have been improve access to language through the interpreter services project. This is also available to behavioral health providers in the network. Anyone can utilize this service, and is a service that provides the interpreting in the moment in the visits. It also involves assessing your medical records. How do you collect the data, but also how do you identify it in your medical records? This could be actually discriminatory and racist, both the way you collect it and the way that is included on the files. So that is important to pay attention to it. Obviously, the education for all about these standards is key. So the PPSC, aside from the cultural and linguistic program, which I'm not sharing any data because time it doesn't allow for that, but if someone wants data, we can share it. PPSC Regional Support Team is a team of community health workers and referral specialists that provide support for social determinants of health and also linguistically appropriate services in this team as well. We have community health workers that come from the communities that we've served in our organization. And as Rachel was mentioning, we already talked and discussed before in this context the importance of having navigators and CHWs and so on that are culturally diverse and attuned to these populations. There is a health needs assessment that PPSC administers at every well-child visit that includes these items here. I can share the health needs assessment as well, and it's also translated to other languages, including Spanish. Now, this regional support team has also a medical home asthma program. So this is where it interfaces with medical care. This team provides incredible services for kids who have poorly managed asthma, trying to connect the strategies to not only how they manage because of lack of education and supports, but also how their environments are affecting the illness and the management of the illness. They include giving supplies to be able to have better environments, but also advocacy for landlords and etc. This is a map flyer for patients and families, also translated, that sets expectations about their visits related to the management of asthma in this program. Then lastly, I wanted to bring out the attention of our program, the Behavioral Health Integration Program, trying to support the regional support team. When a behavioral health need is identified by the PCP, it might go to the behavioral health clinician, who also connects with the regional support team. But there might be also social determinant identified directly by the PCP team that hasn't been also addressed in behavioral health aspects of care, and that can go directly to the regional support team, who in turn can try to collaborate with the behavioral health clinicians. This is not easy because of the structure we have in the PPSC. Community health workers belong to our organization, and the practices we serve have their own behavioral health clinicians embedded. So it's two different organizations working together, and our team, the Behavioral Health Integration Program, supports all these roles, both the clinical, the practice roles, BCP, behavioral health clinician, care coordinators, but also the collaboration with this regional support team that belongs to our organization. So we are available to the regional support team for behavioral health consultations, support with referrals, but also support with engaging with the behavioral health clinicians at the practices. We have more than 50 practices across the state, so we have a lot of community health workers, but never enough. We try to foster that collaboration and also infuse that in the behavioral health clinician teams. And we also think about supporting both primary care physicians and other medical roles, as well as behavioral health clinicians with considering family beliefs, patients' culture and language preferences, and incorporating relevant content about this in the educational activities that we provide the practices. And lastly, here are some of the adapted competencies of the behavioral health clinicians providing culturally responsive care and in helping practices engage in culturally responsive conversations with patients and families. You are all familiar with this, so I don't have to go over, but I wanted to end with this piece. We have a couple of two examples about this collaboration. Kids needing, family needing housing supports, utilities, and also there were some housing issues connected to safety, and the need to have support managing, understanding, and managing asthma. So the regional support team provided support on how to administer the medication properly. And there were also some consequences of this on missing some kids from school hours. The medical home care coordinators in the practices requested assistance, and the outcomes were really successful, assisting with housing, utilities, and safety, supporting with allocating therapies for one of the children, and improving asthma management, as well as improving school attendance. Another example is an older patient, 18-year-old. It looked like they needed a prescriber and also a therapist. Sometimes this is a part of the support that this regional support team gives. If the practices don't have a behavioral health clinician embedded, it might be difficult for the PCPs to understand where to send patients. And by virtue of consulting with us, we can direct them to the best level of care and best services for this presentation that they refer to us. Okay, I think the outcomes was also connecting with the behavioral health. Also food services. We have a program that provides food farm to table services for kids, and a special program as well that for kids who have behavioral health needs. Assisted guardianship application and SSI Social Security income application. So thank you all. This obviously is just a small effort, but also directed to have you all chime in about your own efforts, or how would you envision starting those. And again, nothing is small. Everything matters in developing this type of culturally and linguistically appropriate services, or any other ways to reduce inequities and racism. So please contribute to the conversation. So Matthew, that I'm a good facilitator and say something, write something, put your videos on.
Well, thank you so much, Juice. I was just gonna, as you were presenting, I was just thinking like, wow, you all have a lot of stuff going on and to address these kind of concerns. And you know, Rachel kind of gave the broad overview of like, hey, we need to do this. And you're like, hey, I'm doing it. And here's how I'm doing it, which is great. And so I was kind of wondering, like you were too, like what are other people doing to address kind of this issue of cultural and linguistic competence in their clinic, or what would you hope to be doing?
Yes, it's writing on the chat. They are able to get access to interpreter, but not translation of written materials. Yeah, that's a challenge for us as well. And the biggest challenge after we have the translation of some of the screenings or handouts is also to incorporate them into the medical record. Yeah. There's a question, Rebecca. Are there specific recommendations for implementing changes? And that's a very broad question. I want to be humble myself. I don't, I'm not part of the decision making in the organization, but I think in having your own equity, diversity, and inclusion committees within your organization can go a long way. First, trying to improve the literacy of your organization about EDI, but maybe, also starting to move some of these initiatives. No one likes to look bad when it comes to, addressing issues of equity. So maybe, I don't know, there is a way that you can be influential, but I'm sure people on this call are much more wise and informed than me about this. So please chime in if you have suggestions for implementation and even buy-in. Cultural consultations, something I used to do in my internship. Hey, Christina, do you mind sharing with us how those look in your internship?
Yes, and I don't mind at all. And this is a long time ago. My internship is a long ago, but it was actually a requirement. So if we had any clients, and this was not in a medical setting, so this was not part of integrated behavioral health care, but if we had any clients whose primary language was not English, or who identified, excuse me, with a background that, I don't remember if there was a list that we went by at that time, also for kids who were LGBTQ plus. We had actual contracted consultants. So these were usually therapists in the closer community who might have been in private practice or otherwise, and they had been designated as a cultural consultant. And so we would have at least 20-minute conversation with them, and they would be compensated. This was all state. This was at a community mental health agency, so all of this is state funded. But that is something that hasn't really surfaced. I work for a company now, so it's not, state connected or anything like that. And we do use interpreters in person or on the phone or via video, but we don't have these cultural consultations. And I don't know. I mean, I can access them by trying some networking, but that would be more on my own level. I'd have to. It hasn't. I don't know why it hasn't even occurred to me to think about that. wide. It's a huge clinic. I mean, hundreds and hundreds of providers. So
Thank you so much, Christina, for sharing how you did it, and also for the insight of maybe you have to do it on your own. Like, there are some of these things that unfortunately maybe have to happen without the whole organization, but also, you know, we need to commit personally to be part of the change. So I think if you have the availability to what you used to have is fantastic. But also, you know, finding other ways to educate ourselves about this, and, you know, perhaps end up influencing others by virtue of doing that. You know, it's a two-way street, I think. Anyone else has any feedback to give? Questions or answers?
In terms of implementation, I was just thinking about, you know, if you have different projects or ideas or ways of moving these things forward, you know, I know our health system is a part of lots of different negotiated payer contracts that, you know, we're supposed to meet certain health outcomes and health metrics to even get paid for that, right? And so I think the stuff that you were presenting about is directly related to patient outcomes. So it's the difference between whether people get better or not many times. And so I think if we can, I mean, I think the idea of cultural competence is just important intrinsically, but then like, how do you frame that to some of these interventions in a way that like administrators and other health system people get it too? It's directly related to whether people get better or not.
Yeah. It's also, you know, connecting what you're saying with Christina and yes, it's also, it's not clear that initiatives that come from the organization, when it comes to some of these aspects, right, like educational aspects for the teams, have the desired effect. And there are some articles, you know, mentioning how they stereotype the certain groups and really do not teach. They teach, but the people don't learn this way. You know, you have to be perhaps in a longitudinal and embedded way to understand other cultures and languages. Is not always possible to do so, but I think that's where the humility part comes handy, because you need to understand that you can't understand every culture, every race, every ethnicity. Is impossible, but it's important to have the disposition and the humility to you know, not consider that your culture is better, and also perhaps looking at your own culture. Who, you know, what do you bring to these encounters with people? You also have a culture, not only the person who comes to see you. And we don't really examine that a lot. Our culture that we bring personally, the culture that our organization might have, the culture of healthcare, and the culture of behavioral health care, you know. And from then, there are plenty of other issues, like what is evidence-based care, really evidence-based with wide populations only, or so it's infinite when you start thinking about it. And I think that's the exercise that makes possible that we advance the equity, because we are together thinking and talking about it. And perhaps that's more effective than, you know, going to a training that they tell you something that you don't really are able to learn. Does that make sense?
Yes, that made sense.
So for someone who was asking how can you introduce change? Maybe that's the way we can all introduce change. You know, maybe together here today, we are doing that, but maybe in our own clinics and organizations, small groups can also start conversations and, gaining conscience about these issues is the first step.
Jess, it looked like you had put a book recommendation in the chat. Do you want to talk about that?
Sure. So I recently been taking a deeper dive into really trying to enhance our diversity, equity, inclusion, acceptance and belonging curriculum within our system here or within our department. And one of the books that I recently purchased was Culturally Sensitive Supervision and Training, Diverse Perspectives and Practical Applications, which is the title that I put in the chat. It's a really, I think, user-friendly book. If this is something that you want to do, that you think you're doing, but you want to enhance your understanding of and application of in terms of culturally confident supervision. And one of the reasons it came to mind for me is because understanding your cultural self is something that actually comes through in this book. And it talks about like, how do you create stage for your learners, right? Open the door to have these conversations, not only when you think about that dyad, that relationship that you have with your learners, but also how does this impact your clinical services that you provide. There's another book that I have out, which I haven't done as much exploration in, but I really like the exercises, but it's called the Racial Healing Handbook. And so there's some really nice exercises in here that really kind of require you to really think critically and sit with and be mindful and introspective on some of your own personal experiences and how this has an impact on your relationship with others. So it's basically activities to engage in collective healing. I would assume that some of these activities don't have to be taken from a racial lens, but to be thought from a variety of different multicultural perspectives. But I can put the title of this book in the chat too.
Yes, thank you, Jess.
Mm-hmm. I'm curious to know how, so it's one thing to implement some of the things that you shared with us on a like system level, but even just conversations with like your staff, with the providers with whom you work, with your colleagues, how much buy-in is there into some of this stuff? Do you feel like there's collective buy-in within your clinic to say, yeah, of course, to do these things so that way we can in equity? Do you ever feel like there's pushback, and like how do you navigate some of that?
So we don't provide care in our organization. So we support the clinics that provide care. So that is coming now to a point where we have to figure out if they reach out to us for support with these issues, how do we do that, right? That has happened recently. Also, certain situations in which they found themselves not knowing how to respond, not only hypothetically, theoretically wanting education, but facing real scenarios that require, some literacy about these things. So we are trying to understand how to add that to the support that we give the practices. The other thing is for us internally also, we created an EDI committee for our own employees, and we report to senior management on the things that we think are important to infuse this in the organization, because also when things happen at the practice level and they come to us, it has to be received by people who understand it and not dismiss it, like racial incidents, dismissed and I don't know, issues between staff. So we are not advanced in this. We are trying to get some of our ideas and supports from the Boston Children people on committee, because we are associated with them, but you know how these things are. We are different, so we are a different organization affiliated. And we just conducted a survey last year to start this process, to assess the perceptions of our staff, and repeated the survey recently to see if some initiatives that we implemented were, changing on the way people feel about being in this organization. But we need to work on diversity big time. Not only, the inclusion piece is key, obviously, but we don't have much diversity. We have a lot of diversity in certain aspects of the organization, not in others. But I guess that's for everyone.
So, we've been talking a lot about culturally competent care that we can provide, I think, on a patient level. And Rachel, you were talking about kind of the systems that need to change around that. And one thing that we've been trying to think about at ETSU is how do you hire a behavioral health workforce that is culturally competent and diverse, and how do you recruit and retain them, and create meaningful jobs that aren't just punching a clock, but like that people legit get fulfillment out of. And I didn't know if you or anybody else had thoughts about that, about like how do we apply this concept to growing the workforce rather than just the patient care perspective of it.
Well, I think one of the things is how do you have a workforce that represents the community, right? Creating diversity in general, it might be impossible. Like for every one of us in our organizations, regardless of who we serve, right? But who are you serving in your communities? Because that's representative of the bigger problem, right? Who lives in your communities? Maybe in your communities you have people who are white and certain socioeconomic status, and are you going to hire Black and brown clinicians? So things like, I think it's all like, everything connects with the societal problem. We have, more than 50 practices, and you wouldn't believe the difference between, a Springfield, Massachusetts practice and Brookline practice. It's completely different. So I don't know if for those practices that do not serve the population should start with hiring, because also you have to retain them. So the culture has to be welcoming and inclusive and not only diverse. So I think I'm getting myself into a big loop, but I don't know if I'm making sense to you, but I don't know how your organization is at that level. And I think building the workers from the community that you work with is key. And there are other things like Sandy Blount had this, when he worked with New Hampshire, I think it was, had this career ladder project within the organization, from, going from medical assistant to nurse to like giving opportunities for growth, and not only for retainment, but for, because it's the right thing to do.
Makes sense. And I think Rachel's article was mentioning about, on a community health worker level, at least, how do you recruit those folks in a way that matches the population that you're serving? And I just don't know if we've, at least in East Tennessee, have gotten beyond maybe that level to like people who are at different levels of providing medical or behavioral health care, and how much it matches the population that we serve. I didn't know, Stacy, if you're still with us. Are you in a residency training setting still, or was that a prior job for you?
Say that again.
Are you in a residency training setting?
Yeah, family
family
medicine
med?
and psychology. Mm-hmm.
Yeah, I was wondering your perspective about this, because I think, in a residency training perspective, it's like around educating the future medical workforce or behavioral health workforce. And I'm in a residency training setting here too. I didn't know kind of if this topic came up or came up differently in that academic type setting for you all.
No, I think it goes back to, we've had a problem with this for multiple decades. So I think the discussion of what you all are talking about is unfortunately not new. There's been lots of initiatives that people have tried, starting earlier, starting in middle school, starting in elementary school, of when you get people interested in the health professions. I think some of the initiatives that are out there are somewhat helpful, but it's just such a multi-systemic issue, especially depending on what part of the country that you're in, how diverse the faculty you have are too. That's a big thing. So yeah, I don't have an answer. I'm not sure who does, but those are some things that I just wanted to comment on.
Thank you. Any final thoughts before we head off to the rest of our afternoon? Well, I just appreciate you all so much for joining us, and thanks Rachel and Choose for pulling that material together and facilitating the discussion. And we hope to see you all next month in person at CFHA, and if not, hopefully we'll see you on the next iteration of our Zoom meeting series here. And again, please think about, if you're interested in leadership opportunities within the SIG, we would be happy to connect you with that and provide mentorship to getting more experience with that. So Choose or Rachel, anything else, or Jess, Michelle?
No, just thank you everyone for connecting today. And please volunteer to do this is how we do it segment. We want to hear how people are doing everything. So anything that you might be doing and want to share with us would be awesome.
We will we'll distribute some of the content that we talked about today, the PowerPoints and the article, to you through the email listserv. But if you need anything else, feel free to reach out to any of us specifically, and we'll be happy to talk more offline. But hope you all have a good rest of your day. Oh, it says Christina says that she's facilitating. Let's see.
I'm facilitating the diversity, equity, and inclusion, a discussion group. And part of it is because I need to dive into that more. And so I was hoping that is right to see some of you so that I can learn from you as well. So.
Well, this was like a trial run for your group then, Christina.
Mm-hmm.
Yeah, that's great.
Exactly. It was really helpful.
Now you'll have to go read both those books real quick before the conference. Well, always good to see you all. Yes. We'll talk to you next time. Hope you have a good month.
Bye,
everyone.
Bye everyone.